Welcome back to the Deep Dive. Today our mission is, well, it's to cut through the complexity of a medical topic that frankly harbors one of the great paradoxes in clinical practice. We're doing a high-yield, really focused deep dive on angiomyolipoma, AML for short. And we're not starting in a textbook, no. We're starting somewhere much more chaotic, the emergency room. Picture this, it's 7:42 a.m. Our sources, they paint this really gripping picture. A patient comes in, sudden, just agonizing, searing pain in their flank. They're dizzy, pale, blood pressure plummeting. It's acute, it's life-threatening. The clock's ticking. Priority 1, stabilize and diagnose fast. Okay, let's unpack this dramatic scene, because the diagnosis that follows, it really reveals the ultimate conflict in this tumor type.
You've set the stage perfectly. So the imaging comes up, the diagnosis is concerned, angiomyolipoma. Now, for anyone unfamiliar, AML is, fundamentally, it's classified as a benign renal mass, benign. But here's the kicker. In this specific case, this supposedly harmless tumor, it's causing a catastrophic internal bleed, a spontaneous retroperitoneal hemorrhage. And that contradiction is exactly why AML is so crucial to understand. It's, benign by histology, looking at the cells under a microscope, but potentially, let's say, malignant by behavior. Dangerous. So our deep dive today, it's all about resolving this paradox for you, understanding why this specific tumor acts like a time bomb. Which patients are most at risk? How has cutting-edge molecular knowledge totally revolutionized treatment? And most importantly, what's the clinical playbook? The one that prioritizes saving the patient's life? Yes, but also saving their kidney function. That's key.
Right. That distinction is absolutely core. Benign cells, but dangerous vascular architecture. That's the big takeaway we need to start with. So let's define our villain here. When you break down the name angiomyolipoma, it's actually pretty self-descriptive, isn't it? It sort of gives away its whole composition. Angio, that's blood vessels. Myosmooth muscle cells. And lipofat. So we're looking at this triphasic tumor sitting in the kidney, and I gather the mix of those three things, the ratio, it's pretty important. It determines how dangerous it is, how easy it is to spot.
Exactly. The ratio is critical. And what's fascinating here is that while the name tells you what it's made of, it doesn't quite tell you the origin. See, AML isn't just some random jumble of tissues. It belongs to a specific and often quite rare family of tumors. We call them picomas. That stands for perivascular epithelioid cell tumors. And why does that family connection matter? Well, it matters because these picoma tumors, they all share a cellular ancestry and, crucially, a molecular vulnerability. They arise from these perivascular epithelioid cells, which explains why the tumor is so tightly linked to the blood vessel structure. They also tend to share a specific staining pattern on biopsy, which hints at their similar genetic pathways. And that pattern, it's been absolutely vital for diagnosis and, more recently, for targeted treatment.
Okay, so it's part of this picoma family. Let's circle back to that paradox then. You said the smooth muscle and the fat parts, they're structurally, non-aggressive. They don't invade, they don't spread. But the angio part, the vessels, you said, that's the critical flaw. So how are these vessels different from, say, normal kidney blood vessels? What's wrong with them?
Oh, they're drastically different, fundamentally compromised in several ways. Think about a healthy artery. It's got this smooth, organized, three-layered wall, right? With a strong elastic layer, the lamina. It's built to handle high-pressure pulsatile flow. The vessels inside an AML, they're not just poorly built. They are, the term is dysplastic, malformed. They're missing that crucial elastic tissue layer. So they just can't accommodate pressure changes properly. Instead, they have these overly thick, disorganized, smooth muscle layers. It makes them tortuous, rigid. And because those walls are inherently weak and disorganized, they are incredibly prone to forming these little outpouchings, these bulges we call aneurysms. Those aneurysms are the real ticking time bombs. They balloon out, and eventually, just under the normal pressure of blood flow, they rupture. And that leads directly to the massive, rapid bleeding into the retroperitoneum, the space behind the abdominal lining. That's exactly what our ER patient is experiencing.
Wow. So it's truly a plumbing disaster, isn't it?
Yeah.
Not really a cellular growth disaster in the typical cancer setting.
Exactly.
Okay, so let's lock that in. That crucial high-yield concept. AML has benign histology, dangerous hemodynamics. It's the vessel structure, not the cell behavior, that's the main threat. Got it. Now, to really grasp the implications for risk and how we treat it, you mentioned we need to immediately sort patients into one of two main categories or buckets of AML sporadic versus hereditary. This gives us context, right, for how common it is, likely size, long-term outlook.
Yes, that's a necessary first step, because the underlying reason why the AML developed determines almost everything else from the age it appears to the risk of it coming back. So bucket number 1, This is the vast majority, roughly 80% of cases. This is sporadic AML. These are the ones that seem to pop up randomly, no obvious genetic link. They have a strong tendency to affect women more than men, typically middle-aged women, maybe between 40 and 60. And the key features here: think single and found by chance. They are almost always solitary, just one tumor and unilateral, meaning in only one kidney. Very often they're found incidentally. Someone gets a scan for, I don't know, gallstones or back pain, and oops, there it is. Because they're often small and don't cause symptoms initially. They still carry some bleeding risk, but generally less than the other type.
Okay, so that's sporadic 80%, usually single, incidental, middle-aged women. Now, the second bucket, hereditary or syndromic AML. This is the other 20%, but it sounds like it carries a much heavier clinical weight.
Absolutely. Disproportionately complex and causes more problems. This type is almost always linked to a genetic syndrome. The big one, the dominant one here, is tuberous sclerosis complex, or TSC. If someone has TSC, their lifetime risk of getting one or more AMLs is just staggering. We think it's somewhere between 80 and 90%. Huge. We also see a strong link with another condition called lymphangioliomyomatosis, or LAM.
Wow, 80 to 90% with TSC. That's incredible.
It is. And in these syndromic cases, the clinical picture is totally different from the sporadic ones. Characteristically, these tumors are multiple and bilateral. So they often affect both kidneys, and there can be many of them, sometimes taking up large parts of the kidney tissue. They also tend to show up much earlier in life, sometimes even in childhood or adolescence. And because they're often larger, and there are more of them, they carry the highest baseline risk of bleeding, and also, over time, the risk of losing kidney function altogether. That involvement of both kidneys makes nephron-sparing treatments absolutely non-negotiable. We have to save kidney tissue.
That mnemonic you suggested sounds useful. SS, HM, sporadic equals single, hereditary equals multiple. Just a quick way to frame the initial assessment and maybe think about genetic testing.
Exactly. It's a good mental shortcut. And we should probably pause on that LAM connection for a second. Lymphangioliomyomatosis, LAM, it's itself a rare lung disease, progressive, causes cysts in the lungs. It almost exclusively affects women, typically of reproductive age. We mention it because LAM cells often have the very same underlying molecular defect as TSC cells. So LAM frequently occurs alongside AML, even if the patient doesn't have all the other features of TSC, like the skin or neurological signs. It really reinforces this idea that there's a strong hormonal component involved, especially estrogen sensitivity, that seems to drive the growth and perhaps the vascular fragility in these women.
Okay, so we've got the structure, the angiomyolipoparts, and the two main settings, sporadic and hereditary, with that strong TSC-LAM link. Now let's go deeper. Let's shift from the big picture structure to the microscopic mechanics to really get why the hereditary type is so common in those patients, and crucially, why we actually have effective targeted treatments now. We need to look under the hood at the engine driving it all. Here's where it gets really interesting, the molecular biology that explains the clinical picture.
Right. This takes us into the intricate world of the mTOR pathway. mTOR stands for the mechanistic target of rapamycin. Think of mTOR as sort of the master controller for cell building. Enablism. It coordinates everything related to growth, cell division, making proteins. Basically, if mTOR is switched on, the cell is in growth mode, full steam ahead. Now, in a healthy cell, we have checks and balances. Tumor suppressor genes act like quality control. Specifically for this pathway, we rely on two proteins, TSC1, also called Hamertin, and TSC2, called tuberin. They work together, forming a complex, and their main job, to be the brakes. They directly put the brakes on the mTOR pathway, keeping it in check. They do this by regulating another protein called Rheb, essentially acting like a switch that keeps the go signal off most of the time.
Okay, so TSC1 and TSC2, Hamertin and tuberin, they're the natural brakes on this mTOR growth pathway.
Yeah.
But in tuberous sclerosis complex, those brakes are basically broken from birth.
Exactly. That's the core problem. When a patient inherits a mutation in either the TSC1 or the TSC2 gene, a germline mutation, that braking complex is faulty or maybe completely absent. So what happens? The accelerator mTOR is released from its inhibition. It becomes what we call constitutively active. It's just stuck in the on position, firing nonstop, telling cells, grow, divide, build those disorganized structures relentlessly. And this unchecked signaling is what leads to all the hallmark growths, the hamartomas, seen in TSC, including those numerous bilateral AMLs we just talked about. That sheer, overwhelming growth drive, because the brakes are off, explains why these tumors get so big, why there are so many, and why they appear so early in life in people with TSC.
And this isn't just fascinating biology. Knowing this specific broken mechanism gives us a perfect target for therapy.
Right. It's the absolute poster child for precision medicine. Because we know exactly which break is broken, scientists were able to develop drugs that essentially bypass that broken TSC complex and directly block the downstream effects of all that hyperactivity. And those drugs are the MTO inhibitors. The most well-known one is everolimus. Everolimus acts as a very specific blocker of that MTOR complex itself. By shutting down that hyperactive signaling, we can dramatically slow down or sometimes even halt that relentless proliferative drive. What does that mean clinically? It translates directly to tumor shrinkage, a significantly reduced risk of bleeding, and often it means patients with TSC-associated AMLs can completely avoid invasive surgeries. It really has changed the entire trajectory of care for this specific group of patients. It's been revolutionary.
It feels like such an elegant solution. Identify the broken switch, bring in the inhibitor drugs, stop the uncontrolled growth. That sticky line for everyone listening needs to be crystal clear. Broken brakes on MTO air uncontrolled growth, fixed with MTO inhibitors. Okay, so we've gone from the molecular mechanics back up to the clinical floor. We know why these things grow, especially in TSC. Now let's confront the immediate danger. Most AMLs, you said, stay small, cause no trouble. But when they do make themselves known, the presentation is critical.
That's right. For the majority of patients, the ones with small AMLs found incidentally, careful watching, surveillance is the way to go. But when they do become symptomatic, the complaints can really range from something quite vague to, well, catastrophic. Vague symptoms might be like a persistent, dull ache in the flank. That could be the tumor growing and stretching the kidney capsule. Or maybe microhematuria, tiny amounts of blood in the urine, just indicating those weak vessels are starting to get a bit leaky. But the headline emergency, the reason our patient ended up in the ER at 7:42 a.m., is the spontaneous retroperitoneal bleeding. Clinically, we call this Wunderlich syndrome. And this is absolutely not subtle. It's a rapid, life-threatening event.
Can you paint a clearer picture of Wunderlich syndrome? Describe it in more detail, because this is the urgency we really need to internalize.
Sure. It's classically defined by a triad of symptoms. First, sudden, really acute flank pain, often described as tearing or excruciating. Second, you might feel a palpable mass in the abdomen, which is essentially the collection of blood. And third, signs of internal shock. Specifically, that means low blood pressure hypotension and a rapidly falling hemoglobin count on blood tests, showing active blood loss. When one of those aneurysms ruptures, blood pours out quickly into that retroperitoneal space. This internal volume loss causes hypovolemic shock. That's why the patient is dizzy, pale, while their blood pressure is dropping. It demands immediate fluid resuscitation to stabilize them, followed by urgent intervention to find and stop the source of the bleeding. It's a true emergency.
Which means managing AML really boils down to proactive risk assessment, doesn't it? We have to try and intervene before that acute bleed happens. And that brings us to these critical threshold numbers, the measurements that really dictate the management plan.
Precisely. We absolutely cannot wait for the rupture. The primary number, the metric used pretty much globally, is tumor size. Decades of data, observational studies, have shown very clearly that the risk of spontaneous bleeding goes up dramatically, almost exponentially, once the ML gets bigger than 4 centimeters in diameter. Below 4 centimeters, the risk is statistically low enough that active surveillance is generally considered safe.
Okay, 4 centimeters. Why that specific number? Is it arbitrary or is there physics behind it?
It's not arbitrary at all. There's physics behind it. It relates to wall tension. Think about a sphere, or in this case, a tumor containing a weak blood vessel. As it gets larger, the tension on the vessel wall increases disproportionately. It's related to Laplace's law, essentially. Once that tumor volume crosses the 4 centimeter threshold, the mechanical stress on those already malformed dysplastic vessel walls becomes severe enough that it's much more likely to overcome their structural integrity. Rupture becomes highly probable. So it's based on real-world data linking size to hemorrhage rates.
But you've stressed it's not just about size, right? The quality of the vessels, those aneurysms, matters maybe even more. So what if the tumor is small, say 3 centimeters, but the vessels inside look really bad?
That is the crucial nuance, yes. And it absolutely overrides the 4 centimeter rule. We specifically look for those aneurysms during imaging surveillance. If we identify an aneurysm within the AML that measures greater than 5 millimeters in diameter, just half a centimeter, that feature alone is considered a major independent high-risk factor for bleeding. In that scenario, even if the whole tumor is only, say, 3 centimeters, well below that usual 4 centimeter trigger, we would strongly consider intervening prophylactically because the risk of a catastrophic bleed from that specific aneurysm is just deemed too high to simply watch and wait.
Got it. So 4 centimeters is the volume trigger, but 5 millimeters for an aneurysm is the architectural trigger. Both are vital red flags, equally important. And we touched on this briefly earlier. There's a specific group where the risk is amplified, demanding an even lower threshold for action.
Right.
Pregnancy. Why does pregnancy make AML so much more dangerous?
It goes right back to the components of the tumor, specifically the myo part, the smooth muscle. Just like the smooth muscle in the wall of the uterus, the smooth muscle cells within an AML express receptors for female hormones, particularly estrogen and progesterone. During pregnancy, as you know, these hormone levels surge dramatically. This hormonal surge can trigger rapid enlargement of the AML, we call it tumoral hypertrophy, and it can also increase the already significant fragility of those dysplastic blood vessels, basically pushing them closer to the rupture point.
So the hormones directly fuel growth and potentially weaken the vessels further.
Correct. So for women who are pregnant or even just planning to conceive and have a known AML, we really need to think about proactive intervention. Often that means prophylactic embolization. We'd strongly consider this for tumors that might otherwise just be watched, maybe even those approaching the 4-centimeter mark, or certainly any that have shown growth. We have to mitigate that heightened risk before they get into the 3rd trimester or labor, where blood pressure spikes could be the final straw that triggers a rupture.
Okay, let's nail down those intervention red flags again for everyone. A solid takeaway. 4-centimeter overall size, or aneurysm 5 millimeters, or if the patient is pregnant or planning pregnancy, time to seriously consider shifting from just watching to proactive intervention. Right. Now we know the risks, we know the triggers, we have to actually confirm the diagnosis, whether we're facing that acute bleed in the ER or just found one by chance on a scan. This brings us squarely to the vital role of imaging and that unavoidable diagnostic trap that can really complicate things.
Yes. Imaging is where AML usually makes itself known, or conversely, where it can cause the most confusion. We often start with an ultrasound, USG. On ultrasound, a classic AML typically looks very bright, very reflective. The term is hyperechoic. And that brightness comes from the fatty lipo component, so that's often the first clue.
But just seeing a bright spot isn't enough, right?
Definitely not. Ultrasound isn't specific enough. Lots of things in the kidney can look bright, including, worryingly, some aggressive types of renal cell carcinoma, RCC kidney cancer, which might have areas of fat necrosis or cystic change that can mimic that hyperechoic look. So to move from just suspicion to a confident diagnosis, we really need the specificity of a CT scan. CT is the workhorse here.
And what is it on the CT scan? What specific finding basically seals the deal for AML, often letting us avoid sticking a needle in for a biopsy?
It's the unambiguous proof of macroscopic fat. See, CT scanners measure tissue density using a scale called Hounsfield units, or HU. Water is 0 HU. Bone is very high positive, like plus 1,000 HU. Air is very negative, like negative 1,000 HU. Fat is unique because it's significantly less dense than muscle or fluid. We define macroscopic fat on CT as tissue that measures less than negative 10 Hounsfield units. So when you see a kidney mass on CT and it clearly contains areas that measure, say, negative 20 HU or negative 50 HU or even lower, that's definitive evidence of fat. And in the context of a renal mass, finding macroscopic fat is considered pathognomonic for AML. It basically is AML, which means for a classic-looking AML, we can diagnose and plan management without the risks of a biopsy.
Okay, so finding that negative HU value for fat is key. But, as you warned, there's always an exam trap, a clinical challenge, and here it is. The fat-poor AML. This sounds like where the diagnostic certainty just evaporates.
It really does. The fat-poor AML is the chief diagnostic headache. It happens when that triphasic balance shifts. The tumor is mostly made up of the smooth muscle myo or the vascular angio components with very little mature fat tissue mixed in. If that fat component makes up less than, say, 25% of the tumor volume, the overall density of the mass on the CT scan might not actually drop below that critical NACTIC 10 HU threshold. It might look like plus 20 HU or plus 30 HU, just like regular kidney tissue or other solid masses. And in that situation, what you see on the PT is just a dense, solid renal mass. And when a radiologist or urologist sees a solid renal mass, the number one concern, the diagnosis you absolutely must rule out, is renal cell carcinoma, RCC, kidney cancer. Because RCC is aggressive, it needs prompt treatment, usually surgery. If you mistakenly call a fat-poor AML benign and just watch it when it's actually an RCC, well, you've potentially cost the patient their chance at a cure. It's a high-stakes differential.
So how do you navigate that ambiguity? If the CT isn't showing clear fat, what are the next steps? Are there other imaging tricks, or do you just have to get tissue?
Well, we usually move to MRI as the next line of defense before jumping to invasive procedures like biopsy. MRI is often much better at characterizing tissues than CT. Specifically, we use special MRI sequences, things like fat-suppressed sequences, and particularly chemical shift imaging. These techniques are designed to detect even tiny amounts of microscopic fat that the CT scan just couldn't pick up or quantify accurately.
And chemical shift, how does that work?
Essentially, chemical shift imaging exploits the different frequencies at which fat and water protons resonate in a magnetic field. By comparing images acquired at slightly different timings, in phase and out of phase, we can see if there's signal loss in areas suspected of containing fat when fat and water signals cancel each other out. If we see that characteristic signal drop on the out-of-phase images compared to the in-phase images within the tumor, it gives us much higher confidence that microscopic fat is present, strongly tipping the diagnosis towards fat-poor AML. However, if the MRI is still equivocal, if there's any lingering doubt whatsoever, then yes, we absolutely must get tissue. That usually means either a percutaneous biopsy, sticking a needle in, or proceeding directly to surgical removal, usually a partial nephrectomy, for definitive diagnosis. You just can't risk missing an RCC.
Okay. And what about our patient back in the ER at 7:42 a.m., the one who's actively bleeding? Does that immediate crisis change the diagnostic approach?
It simplifies the initial plan but complicates the urgent treatment, if that makes sense. In an acute bleed, the diagnosis of AML might be strongly suspected from the CT. You see blood, you see a renal mass, maybe you get a hint of fat if you're lucky. But the absolute top priority instantly shifts from what is this to stop the bleeding, damage control. So we move immediately to angiography. But now, angiography isn't primarily for diagnosis. It's an interventional tool. We need that angiogram, the dye study of the arteries, to visualize the exact source of the hemorrhage, find those twisted, tortuous vessels, pinpoint the ruptured aneurysm so the interventional radiologist can go in and plug the leak as quickly and precisely as possible.
So angiography becomes the roadmap for intervention in the emergency setting, guiding the treatment rather than just confirming the tumor type.
Precisely. It's about finding the target for embolization.
Okay, so diagnostic phase done, or at least managed in the emergency. Let's pivot now to the modern management playbook. You mentioned this guiding principle, nephron preservation. Saving kidney function is absolutely paramount and has really defined this shift in how AML is treated over the last couple of decades.
Yes. If we connect this to the bigger picture, the whole philosophy has changed. It used to be, a large AML often meant an automatic radical nephrectomy. The whole kidney came out. Today, that's really seen as a failure of care unless it's absolutely, utterly unavoidable. Kidney sparing is the goal.
Let's start with the baseline then. For the majority of these small, incidentally found AMLs, the first line is simply watching, active surveillance.
Correct. Active surveillance, or watchful waiting, is the standard approach for AMLs that are definitely less than 4 centimeters, are causing no symptoms, and show no evidence of those high-risk aneurysms like 1.5 millimeter on imaging. Surveillance isn't doing nothing, though. It means periodic monitoring, typically with ultrasound, CT, or MRI. Maybe every 6 to 12 months at first, then maybe less frequently if it's stable. We're watching to make sure the tumor isn't growing rapidly and that the vascular structure isn't changing in a dangerous way. The whole point is to avoid unnecessary procedures while still catching any progression early enough to act.
Okay, surveillance for the small, stable ones. But once the decision is made to intervene, based on those triggers we hammered home, size 4 centimeters, aneurysm 5 millimeters, symptoms, growth, pregnancy, what's on the menu, you said it's a precise set of options, all aimed at saving kidney function.
Exactly. We have a tiered approach. Let's start with the immediate answer for the acute crisis, the tool used on our ER patient, selective arterial embolization, SAE.
All right, plug in the leak.
Precisely. SAE is the absolute first-line treatment for an acute hemorrhage from an AML. It's also used prophylactically for high-risk lesions before they bleed. It's a huge advance because it's minimally invasive. An interventional radiologist threads a tiny catheter, usually through an artery in the groin, up into the renal artery, and then navigates it selectively right into the specific smaller vessels that are feeding the AML itself. Then they inject an embolic agent. This could be tiny particles, small metal coils, sometimes even a medical-grade glue to intentionally block off, to infarct the blood supply only to the tumor. The benefits are enormous. It's fast. It's highly effective at stopping the bleeding, almost immediately achieving hemostasis. And crucially, it saves the kidney. We're shutting down the faulty plumbing, supplying the tumor while keeping the blood flow to the rest of the healthy kidney intact.
That sounds ideal for the emergency. Are there downsides?
The main trade-off is durability. AMLs often have a really complex branching blood supply, what we call collateral circulation. So even after a successful embolization, sometimes new vessels can grow back into the treated area over time. That's called revascularization. This might mean the procedure needs to be repeated, sometimes years later, but it's still far preferable to losing the kidney.
Okay, SAE for the bleed or high-risk features. Next up, the targeted medical treatment, those MTOR inhibitors, which you said are revolutionary, especially for the hereditary group.
Yes, for patients with TSC-associated AML, this is where medical therapy really shines. Imagine someone with tuberous sclerosis. Maybe they have 5, 10, even more AMLs scattered throughout both kidneys. Surgery is clearly not a feasible option there. You can't just keep cutting out bits of both kidneys without eventually causing chronic kidney failure. This is where MTOR inhibitors like everolimus come in. These are pills taken orally, and they work systemically throughout the body. Major clinical trials like the EXIST-2 trial proved that everolimus can significantly shrink the volume of these TSC-associated AMLs, often reducing their size by 50% or even more. This shrinkage pushes them back below that high-risk 4-centimeter threshold, dramatically reducing the likelihood of bleeding and often avoiding the need for embolization or surgery altogether. For patients with bilateral disease, MTOR inhibitors are really the cornerstone of management now. They provide global tumor control and protect a patient's long-term kidney function. It's a genuine paradigm shift, moving from just reacting to bleeds to proactively controlling the underlying disease process with a targeted molecule.
That sounds incredibly effective for the TSC group. So the logical question then is, why don't we just use MTOR inhibitors for all AMLs? Even the sporadic single ones. If they shrink tumors, why not use them more broadly?
That's an excellent question, and it really highlights the necessary risk-benefit calculation we always have to make in medicine. For a patient with a single sporadic AML in one kidney, they have to weigh their options. Option 1 might be a one-time definitive kidney-sparing procedure like embolization, or more likely a partial nephrectomy to remove just the tumor. Option 2 is committing to lifelong, daily systemic medication with an MTOR inhibitor. And while effective, these drugs aren't without potential side effects. They can cause things like mouth ulcers, skin rashes, metabolic changes like high cholesterol or blood sugar, and importantly, some degree of immunosuppression, increasing infection risk. So for many patients with a solitary lesion, the idea of a one-and-done surgical or interventional cure, provided it can be done safely while preserving most of the kidney, is often more appealing than lifelong medication. MTOR inhibitors are therefore primarily reserved for patients where surgery is either impossible, like extensive bilateral disease and TSC, or considered too high risk.
That makes sense. Tailoring the approach based on the overall disease burden and patient preference. So finally, where does traditional surgery actually fit into this modern management plan? When do you still need to cut?
Surgery definitely still has its place, but it's reserved for specific, necessary circumstances. The preferred technique, whenever possible, is nephron-sparing surgery, which usually means a partial nephrectomy. That's where the surgeon removes only the tumor along with a small margin of healthy kidney tissue around it, leaving the rest of the kidney intact. We typically use partial nephrectomy in two main situations. First, if the AML is absolutely giant, causing significant symptoms just due to its sheer size like pain or pressure on other organs, mass effect, and embolization isn't suitable or sufficient. Second, and probably more commonly nowadays, we use it when we cannot definitively rule out malignancy. If we're dealing with one of those tricky fat-poor AMLs, and even after MRI the imaging remains ambiguous about whether it could be RCC, then a partial nephrectomy serves a dual purpose. It removes the potentially dangerous mass and provides the definitive tissue sample for the pathologist to examine and give a final answer. It's the necessary diagnostic tiebreaker in uncertain cases.
And what about taking the whole kidney out, radical nephrectomy? Is that ever done anymore for AML?
Radical nephrectomy is truly the last resort. It's reserved only for situations where the kidney is essentially destroyed and non-salvageable, perhaps after a massive, uncontrolled hemorrhage that has obliterated the kidney tissue. Or, in extremely rare cases, maybe a gigantic tumor that's deeply involving the main kidney blood vessels or collecting system, making a partial removal technically impossible, and the diagnosis still remains highly uncertain even after biopsy attempts. But the overwhelming principle, the driving sentiment in modern urology is, if the kidney can possibly be saved, it must be saved. Radical nephrectomy for AML is now very uncommon.
Okay, so the modern picture is really a sophisticated blend. Use active surveillance for the small, uncomplicated ones. Use SAE for immediate bleeding control or high-risk features. Use MTOR inhibitors for systemic prophylactic control, especially in bilateral TSC disease. And reserve partial nephrectomy mainly for diagnostic uncertainty in fat-poor lesions or for mechanical removal of giant tumors. That strategy is kidney-sparing care. Right? To really bring all these details home, make them stick, let's run through 4 key case pros. These should reflect the most common, maybe the most challenging scenarios you actually encounter managing AML.
Sounds good. Case Pearl 1, the pregnant patient. We've touched on this, but it bears repeating. Recognizing that heightened hormonal risk is critical. If a woman presents with an AML and she's pregnant, or even just planning to conceive soon, we absolutely must adopt a highly proactive stance. We'd often recommend prophylactic embolization for any lesion that's getting close to that 4 centimeter mark, or certainly one that has clearly shown growth recently. Ideally, this intervention happens before pregnancy or very early in the first trimester. The goal is simple: preempt the risks associated with those third trimester hormonal surges and blood pressure changes. Don't wait for trouble.
Okay, Pearl 1. Be aggressive prophylactically in pregnancy. Case Pearl 2. The fat-poor dilemma. This is all about handling that diagnostic uncertainty, right?
Exactly. When your CT and even your MRI fail to confidently show fat, and you're left staring at a solid renal mass with a differential diagnosis that includes renal cell carcinoma, the absolute priority shifts. It's no longer about confirming AML, it's about ruling out cancer. This means you should not hesitate to recommend a percutaneous biopsy to try and get a tissue diagnosis. Sometimes biopsies can be non-diagnostic, though, just due to sampling error. If the biopsy doesn't give a clear answer, or if your clinical suspicion for RCC remains high despite a benign biopsy result, then proceeding to a partial nephrectomy is the safest, most definitive path. It removes the questionable lesion entirely for thorough examination and protects the patient from the potentially catastrophic consequences of missing an underlying kidney cancer. Don't gamble when cancer is on the table.
Pearl 2. Biopsy or remove if fat-poor imaging is uncertain. Don't hesitate to rule out RCC. Okay, case Pearl 3. The tuberous sclerosis patient. This is the hallmark hereditary scenario.
Right. In TSC, remember the disease is systemic, it's genetic, and the AMLs are typically multiple and bilateral. Therefore, the treatment approach needs to be systemic too. For these patients, particularly if their tumors are approaching the size threshold or are numerous, the immediate default consideration should be initiating treatment with an mTOR inhibitor like everolimus. This medical intervention can genuinely be life-changing and kidney-saving for them. It's about managing the underlying disease process globally, controlling all the lesions simultaneously, not just reacting to one problematic tumor at a time. The long-term goal is preserving as much kidney function for as long as possible. Think systemic disease, systemic treatment.
Pearl 3. For TSC, think mTOR inhibitors first for bilateral multiple AMLs to preserve long-term function. And finally, case Pearl 4, bringing it back to that critical vascular structure.
Yes, case Pearl 4. The aneurysm overrides the size rule. This is perhaps one of the most crucial practical details for risk stratification and surveillance. If your routine follow-up imaging, whether it's CT or MRI, clearly identifies one of those dysplastic vessels within the AML that has formed an aneurysm measuring greater than 5 millimeters in diameter, you need to act. Treat that lesion proactively, usually with embolization. Do this even if the overall tumor size is only 2 or 3 centimeters, well below the usual 4-centimeter threshold. Why? Because that specific aneurysm represents a focal point of high rupture risk. You treat the high-risk feature, not just the overall volume. The takeaway is aneurysm size dictates acute bleeding risk, independent of total tumor size.
Pearl 4. Aneurysm 5 millimeters is a red flag demanding treatment, regardless of the AML's total size.
Got it.
That was really practical. Now, before we wrap up the clinical side, let's just quickly tie this back to the lab bench. For completeness, if we do get tissue from a biopsy or surgery, what confirms the diagnosis definitively?
Absolutely. If a specimen goes to pathology, the pathologist looks for that characteristic histology we mentioned earlier, that haphazard mix of the three components. You see the abnormal, thick-walled, often poorly organized blood vessels, angio. You see nests or bundles of spindle-shaped or sometimes more rounded epithelioid, smooth muscle cells, hyo. And you see areas of mature fat tissue, adipose tissue, lipo. That triphasic pattern is the hallmark. And then, because AML is part of that PEComa family, the definitive confirmation often comes from special stains called immunohistochemistry, or IHC. AML cells characteristically show strong positive staining for HMB45. This is actually a melanoma marker, believe it or not, but it reflects their shared cellular origin pathway with melanocytes. They also often stain positive for other markers like melanate, another melanoma marker, and SMA, which stands for smooth muscle actin, confirming the muscle component. Seeing that HMB45 positivity in a kidney tumor that has the right microscopic look pretty much seals the diagnosis of AML.
Okay, HMB45 positive. Good to know for the final confirmation, right? We have really covered a lot of ground here. We've journeyed from the chaos of that ER presentation down into the mTOR genetics driving the growth through understanding those crucial risk markers like size and aneurysms, and finally landed on the modern kidney-sparing management strategies. So what does this all mean? Let's bring it back to that patient who started our whole deep dive, the one arriving at 5:42 a.m. What happens next for them based on everything we've discussed?
It means that by recognizing that classic clinical triad of Wunderlich syndrome, the sudden flank pain, the signs of shock, the falling hemoglobin, the emergency team knew they had an acute retroperitoneal hemorrhage and had to act fast. The urgent CT scan likely confirmed a renal mass consistent with AML, maybe even showing macroscopic fat, allowing a rapid presumptive diagnosis. But more critically in that moment, the CT almost certainly showed active extravasation contrast dye leaking out of a vessel confirming the active bleed. The decision pathway then becomes crystal clear. Immediate fluid resuscitation, blood transfusion if needed to stabilize the blood pressure, followed by rapid transfer to the interventional radiology suite for that selective arterial embolization, SAE we detailed. The IR doc would use angiography to find the bleeding vessel, the ruptured aneurysm, and deploy coils or particles to selectively block it off. The bleeding stops, the patient stabilizes, and, most importantly, the team has successfully preserved the function of the affected kidney by avoiding an emergency nephrectomy. That's the modern success story for acute AML hemorrhage. And really, the central lesson, the thing that rewards this kind of deep dive into AML, is mastering that pattern recognition. Understanding that a benign classification on paper offers false reassurance. It's the biology of those dysplastic vessels that matters far more than the histology of the individual cells. AML rewards vigilance defined by those 4 centimeters and 5 millimeter triggers. And its management today is fundamentally driven by prioritizing kidney preservation, using this fantastic toolkit of modern, minimally invasive techniques like SAE and targeted molecular therapies like mTOR inhibitors.
A fantastic summary. Benign histology does not mean benign behavior. Pattern recognition and nephron preservation are key. And that successful management path, especially leaning so heavily now on targeted therapy like mTOR inhibitors for the TSC population, leaves us with one final provocative thought for you, our listener, to consider. Given the really quite dramatic success of mTOR inhibitors in shrinking these bilateral TSC-associated AMLs, often allowing patients to avoid invasive surgery entirely, this raises a really important long-term question. Think about a young patient diagnosed with TSC. They face lifelong management. What are the real long-term trade-offs for them? Is it better to commit to permanent, daily systemic medication with an mTOR inhibitor, accepting the potential side effects, the need for constant adherence, the impact on quality of life? Or is the alternative path potentially better, facing the possibility of needing repeated, delayed, but perhaps more localized procedures like embolization, or maybe even a partial nephrectomy down the line if a specific lesion becomes problematic? It's this complex calculation, isn't it?
Weighing immediate safety and tumor control from the medication against the potential long-term cumulative burden of side effects versus the risks and recovery from intermittent procedures. That's a challenging conversation that clinicians and patients with TSC AML have to navigate every single day, something to definitely mull over.